Good morning or good afternoon to everyone, as the case may be. I'm Nancy Pottishman from the Office of Dietary Supplements at the NIH. We call that ODS. On behalf of ODS, we want to welcome all of those tuning in, zooming in for these webinars. It's the culmination of hard work and fine-tuning on issues of importance to many of us in the field of nutritional sciences. The Office of Dietary Supplements is very interested in characterizing dietary supplement users, documenting the types of dietary supplements being taken, and any health benefits or risks related to dietary supplements. And given the importance of total nutrient intake from food and dietary supplements, obtaining the best dietary data is critical in addition to the dietary supplement information. The mission of ODS is to strengthen knowledge and understanding of dietary supplements by evaluating scientific information, stimulating and supporting research, disseminating research results, and educating the public to foster an enhanced quality of life and health for the US population. In addition, one of the things we need to do is to conduct and coordinate scientific research related to dietary supplements. One of our programs, the Population Studies Program, evaluates the use of dietary supplements by the US population and specific subgroups and the contributions that dietary supplements make to nutritional status. And we also lead efforts to address methodologic issues in assessing dietary and dietary supplement intakes relative to epidemiologic and other large studies. So it's fitting that we support the topics of the 4 seminars in this series. There are 2 target groups from which it is particularly difficult to obtain reliable, reproducible, and valid intake information. They were identified by our colleagues at other NIH institutes and the dietary guidelines committees as groups for whom more information was needed and hopefully would be available for the next iteration of the dietary guidelines. And there was a group of us, many of us at ODS, who were working on this, and I'm thankful for all their support as well. It was our intent to have national experts summarize challenges and state-of-the-art recommendations and make suggestions on best practices for assessing food and dietary supplement intakes in pregnant women and children ages 2 to 11. We wish to thank the organizers at the National Academy of Sciences, particularly Anne Yakteen, Maria Oria, and Alice Voros-Marti, and the planning committee who took on this challenge, resulting in agendas that are extremely promising in delivering exactly what was requested and hoped for. On behalf of many of us at ODS, we appreciate the efforts and thank the planning committee, the speakers, and the staff at the National Academies for their thought, planning, and resulting subject matter content for these webinars related to these 2 population groups. I look forward to all of these webinars, and I now pass on the spotlight to Cheryl Anderson, who's going to introduce the first webinar.
Thank you very much, and hello everyone. I'm Cheryl Anderson. I'm chair of the planning committee for this webinar series. I'd like to thank our sponsors, and I'd like to thank each of you for joining us today for this, the first of 4 webinars on approaches to assessing dietary intake, including food and supplements in pregnant women and children aged 2 to 11 years old. We have, as I just mentioned, 3 additional webinars. You'll see those dates, times, and topics placed on the screen right now. And I hope that you will join us again on the 17th of May, the 19th of May, and the 24th of May. You'll be able to find additional information about these on the National Academies of Science, Engineering, and Medicine website. I have a few notes about the format of today's webinar. We will hear from our speakers about the best practices, state-of-the-art techniques when thinking about dietary assessment in pregnancy. We'll focus on research and surveillance and some of the analytic methods that are associated with the use of these tools. After our presentations, we'll have a question and answer period with the planning committee members. You can anticipate a 5-minute break at 11:10. We'll start promptly at 11:15 with one more talk, and then have a panel discussion that allows you, the audience, to send in your questions via the Zoom Q&A feature. Please do so, and we'll get to as many of those as we possibly can. This webinar is being recorded, and it'll be published on the National Academies website. Now, I'm really excited about the session that we've planned for you today. As nutrition scientists, dietary assessment tools that are available to us are varied in terms of the strengths that they have for the kind of work that we're trying to do and their limitations. And so I'd just like to set the stage, remind us of, kind of what's going on in the general world of dietary assessment. Well, we know that the tools, the classic tools, range from everything from direct observation to us being able to collect duplicate diet samples. Some things are subjectively reported to us via recalls or records, or we get diet histories. We often use close-ended surveys, including food frequency questionnaires, when we're talking about large-scale human research studies. There are also some emerging tools, mobile techniques, including the use of photography. We have some potential with ecological momentary assessments. There's some objectives tools that are still yet passive, and we'll explore some of the classics as well as the emerging tools, but within these very critical life stages that have been arguably understudied, and for which all of us today would appreciate really hearing about where the best practices lie. Those practices, of course, require that we make some considerations as we're going through thinking about this work. First and foremost, what's the goal of the work? We need to match our tools to our research objectives. We also need to think about the accuracy of the tools that we're using, whether or not they're feasible. Some of them are simply not suitable for large-scale epidemiologic studies. They're not suitable if you're thinking about needing to do multiple measurements over time. You could find that they have large respondent burdens, or they're time-consuming. They require a lot of staff and methodological expertise. We aim to be efficient in how we think about the financial and cost issues of a study, and sometimes they can be costly. We need to think about whether or not they apply to diverse samples. Are they available in multiple languages? Can they be used with special populations? What's the level of literacy that's required? And how highly motivated might people need to be to offer, whether it's the initial assessment or follow-up assessments that could be necessary. We know also that there's a time frame within which we're trying to generally capture information, whether it is acute intake or something that's more chronic or typical or usual intake. And the level of detail that gets provided around those timeframes is something, again, to consider about the tools. Not to be underemphasized is the analytic capabilities of the team once the tools get employed. And so we have brought into the webinar series experts that will allow us to dive into each of the considerations that you see listed here, and they will do it for the specific stages. Today we focus on pregnancy. In webinar 2, we'll focus on children aged 2 to 5. In webinar 3, we'll focus on children aged 6 to 11. And then webinar 4, we'll have a higher level conversation around some of the special considerations. And so with that, I would like to ask my colleague, Dr. Ana Maria Siega-Rees, to now take the microphone to talk with us about what you can expect in today's webinar series.
Thank you, Cheryl. I appreciate that. And let me go ahead and share my screen so that you can see the topic at hand, which is to really think about the specific considerations during pregnancy when assessing diet. And one of the assumptions that I think most of us make is the fact that diet doesn't change over the course of pregnancy. And I guess we need to ask, is that really true or not? So based on my experience of having conducted research in the last 20 years, what we have seen from our cohort studies, as well as some of the focus groups that we have done among pregnant women, is that we do see some increases in the amount of foods normally eaten. We see slight reductions in certain foods, caffeine and alcohol, though we know that there's a lot of underestimation when it comes to alcohol intake because a lot of women who might be consuming it will not tell us. There's slight increases in dairy and protein sources, specifically for vegetarians. And there appears to be a greater change for women whose income allows for this particular change to take place. And I can see that I need to swap my screen. Thank you. There we go. Better. Okay. So recently, we've been very fortunate that there's been a few systematic reviews done in this area. And let me share with you some of the results of the 2 systematic reviews that have been done. So this systematic review looked at studies that assess dietary changes from before pregnancy to during pregnancy. They reviewed the literature from 1998 to 2014 and found 9 studies that actually assess this. And the reason why you're not seeing a whole lot of studies here in this particular area is from the fact that it's hard to get the preconceptional period. We're more likely to get the flip side of it, which we'll talk about in the next systematic review. And so these studies actually showed that the majority do report an increase in energy intake during pregnancy, and that there is a significant increase in fruit and vegetable consumption, a decrease in egg, fried and fast food, as well as coffee and tea consumption from before pregnancy to during pregnancy. And there were just a few of these studies, just like half of them, that actually assessed what were those changes due to and the sociodemographic characteristics associated with those changes. And what we found was that age, education, and pregnancy intention is associated with healthy dietary changes, which makes sense. Now, when you look at the flip side, which is more common to be able to assess dietary intake during pregnancy and then in the postpartum period, you see there were more studies. There were 17 from about the same time period. 8 evaluated diet once each trimester. And these were studies that looked at energy intake, macronutrient and micronutrient changes, food group changes, dietary indices, and sometimes they looked at the whole diet approach. The results were that they found mixed findings for changes in energy and micronutrient intake. So some evidence that there were changes and some that there were not. So it was inconclusive. Most studies did report a significant decrease in fruit and vegetable consumption from the pregnancy state to the postpartum state. And they also found lower diet quality and adherence to a healthier dietary pattern from that transition. So in fact, it literally is the flip side of what we see, but it's in agreement with the studies that we just saw in the other systematic review. And then they were able to show that women with lower educational level, lower income, and or who worked full-time tended to have poorer dietary patterns post-pregnancy. So there is some suggestion that pregnancy is a vulnerable time period that women are willing to make changes. So the next question that comes into play is how many assessments are needed to characterize pregnancy over the 9-month time period? And here I think it's important to remember that that 9-month time period is a shorter time period than any other sort of diet disease relationships that most of us are interested in. But even with that, Do we do one dietary assessment per semester? Do we do monthly dietary assessment intakes? So you get 9 if you're lucky. Do we do multiple regardless? Do we do 2 each trimester? Do we do 2 over the course of pregnancy? And truly, how correlated are the data? And the reason why you need to think about those multiple assessments is because there are different changes that are going on through the course of pregnancy. We have nausea and vomiting that occurs early on. Sometimes it lasts the whole pregnancy. And so how do you actually assess the effect of nausea and vomiting on intake of nutrients and food groups? There are some myths around eating for 2 and cravings that can alter typical dietary choices, some of that for the better or the worse. And so do you assess that separately, or do you assess diet frequently enough to be able to pick up those changes? There's also some pregnancy complications that results in dietary changes for women, and most notably being diagnosed with gestational diabetes. And then in the 3rd trimester, because the baby is growing, there's less size, less room in the abdomen. A lot of pregnant women report decreased appetites and physical activity levels. And then the last 2 issues are something that are generic in the sense that most of the time we don't take beverages into consideration when we're addressing dietary patterns. And to what extent should we be doing that? And last but not least, what about supplements? How and when do we account for them? And so we invited these 4 speakers here today to be able to present some information that they are actually working on that addresses some of these pregnancy challenges. So the first speaker is Kate Sauter from the University of Colorado, and she'll be talking about estimating intake of dietary supplements during pregnancy. Elizabeth Wyden from the University of Texas at Austin, and she'll be talking about dietary assessment during pregnancy, perspectives from a nutritional phenotyping cohort. And Sophie Morzette from Laval University, Quebec City, will be talking about a French-Canadian perspective in assessing dietary intake during pregnancy. And finally, Daniela Sotores Alvarez from the University of North Carolina at Chapel Hill, who will be talking about analytical methods to estimate dietary intake during pregnancy. And let me remind you once again that we'll be taking questions from the first 3 for the panel as well as for the workshop scientists first. And then we'll take questions from Daniela Sotores after she finishes. And then we'll have a panel discussion that will be opened up to the full audience. So thank you. And with that, I pass this on to Kate.
Thank you, Anna Maria. I'm very glad to present today and to share with all of you information on best practices for estimating intake of dietary supplements in pregnancy. I want to start by centering us on why it is important to consider dietary supplements in pregnancy research. Nationally representative data indicate that micronutrient inadequacies in pregnancy are actually very common. More than 4 of 5 women are not getting enough vitamin D, vitamin E, or iron from food sources alone during pregnancy. And at least 1 in 4 women are not getting enough vitamin B6, folate, vitamin C, calcium, magnesium, or zinc. Risks of inadequate intake are also higher for women who are following special diets. For example, women who adhere to a vegan diet are at a higher risk of inadequate intake of B12, D, calcium, iron, iodine, and omega-3 fatty acids. And moreover, all women face barriers to eating a nutritionally adequate diet in pregnancy, which can range from insufficient knowledge or cooking skills, or the time, cost, and effort required to obtain healthy and balanced meals for confirming. Okay, so there are all kinds of complications that can affect what a woman can consume. And unfortunately, the risks of inadequate intake for the pregnant woman and their developing baby are significant. Most well-known are the risks of neural tube defects with inadequate folic acid intake, or risks of low birth weight with insufficient iron. But there's also good evidence for other micronutrients such as vitamin A, calcium, and omega-3 fatty acids. The prevalence and implications of inadequate intake has been well disseminated, and this message has been received by both clinicians and the public. Micronutrient supplementation is formally recommended by the American College of Obstetrics and Gynecologists for both pregnant women and those of childbearing potential. And 3 out of 4 women in the US take a prenatal vitamin on any given day of the pregnant women, with over 95% of pregnant women reporting dietary supplement use at some point during pregnancy. Because dietary supplements are so widely used, not assessing what a woman takes during pregnancy provides an incomplete picture of nutrient intake, leaving a gaping hole in our knowledge. So with that context, let's review some best practices for assessing dietary supplement use in pregnancy. I'm going to discuss frequency of assessment, how to prepare the woman for assessment, and what critical details to collect. I'll give some specific tips for assessing dietary supplements in parallel with 24-hour recalls, food frequency questionnaires, and food records. And then I'll end with highlighting some limitations of dietary supplement assessments that are nearly unavoidable and should be considered when interpreting data. Regarding frequency of assessment, more frequent is better because use of dietary supplements increases across pregnancy from about 60% in the first trimester to over 90% in the third trimester. And further, the specific products being used change during pregnancy due to personal preference, provider recommendation, or system-level changes in formularies. Because of this variability in dietary supplement use over the 9-month prenatal period, multiple assessments is optimal to both capture this change and also limit reliance on longer-term recalls. When it's time to assess the dietary supplements, it's important to prepare the woman for assessment. The key here is helping her report exactly what she's taking. There are over 450 supplements specifically marketed to pregnant women, along with 1,300 general multivitamin products. Even within a single manufacturer, like One A Day shown here, there are a variety of pregnancy-related supplements. So simply noting the brand name won't provide sufficient detail for estimating intake. So to help with this, ask the woman to bring the containers to appointment or to snap a picture of it to show or send to the assessor. The specific name and brand are critical details you should collect. In addition, it's important to ask about the dose, frequency, and be clear about the reference time period. From this information, you can construct a medication log that can give in-depth micronutrient intake data for your desired reference period. If dietary supplement assessment is being done in parallel with 24-hour recalls, you have 2 main options. First, you can use the supplement module embedded in systems like the NDSR or the ASA24 to query dietary supplement use in that 24-hour period. These systems are linked to dietary supplement databases, so they can easily provide the detailed micronutrient information you want. But the major limitation of querying dietary supplements for only that 24-hour period is that if she didn't take the supplement on a given day for whatever reason, it won't be captured at all. An alternative is to use an external dietary supplement log to get a more comprehensive picture of intake. For example, NHANES administers 24-hour recalls, but then also records use of all supplements in the last 30 days. Because dietary supplements can be used episodically in pregnancy, assessments covering more than 24 hours is important for accurately measuring intake. Note that this external log will require more post-collection processing than the recall questions because it will be done outside of a recall system. You'll have to carefully consider your research question and the available resources to decide which method is best. If you're using food frequency questionnaires, you again have the option of using the embedded questions. The major benefit is still getting easily estimated intake from the FFQ analytic system. But the major limitation is that the restricted answer options preclude collecting very detailed information. For example, the diet history questionnaire used by the National Cancer Institute asked what vitamins and dietary supplements were taken in the last month, with broad answer options and no opportunity to select a specific brand or type. Thus, the estimated micronutrient intake will be based on a generic or average of available products. Because there is wide variation in supplement content, relying on this kind of general data is a major limitation. Some FFQs, like the Harvard FFQ, do allow write-ins of specific brands or types of supplements. And this can help in accuracy, but it may still result in missing data if the number of supplements being used exceeds the number of write-in slots. If the FFQ you selected does not provide the detail you want, you can again use an external supplement log, providing you have the resources to do that post-collection processing outside of the FFQ system. And last, if you're using food records, you can easily include dietary supplements in the log. Just like for foods and beverages, you'll need to ask about the brand type, dose, and timing. You may also want to use a separate supplement log to assess use over a different time period than the food log. For example, most food records are done for 3 days or maybe 7 days, but you may want to capture dietary supplement use over the last month or another window. For either approach, you'll be doing post-collection cleaning and processing. So again, it's a matter of deciding what data is best suited for your specific research question. So now I'd like to close with highlighting a few limitations that are inherent to assessing micronutrient intake from dietary supplements. These are issues you'll need to keep in mind as you collect, analyze, interpret, and even disseminate your findings. First, despite your best efforts, some women cannot or will not tell you exact details about everything that they're taking. Doing more frequent assessments can help them remember the target period, can help them remember details more proximately to the target period, as opposed to waiting until the end of pregnancy to recall supplements used over the entire prior 9 months. You'll also need to have a plan for missing or incomplete data, whether it be excluding those women or some sort of data imputation. And second, remember that what is listed on the bottle or reported on the manufacturer's website does not mean that is exactly what is in the bottle. Dietary supplements are not regulated by the FDA, and lab analyses show that actual content can vary from the label by as much as 20%. They could also contain contaminants that could affect ingredients or have implications for the health outcomes you're studying. The NIH Dietary Supplement database provides adjusted values for all supplements based on lab analyses of each type of product. So it's a very useful resource in that sense. However, the discrepancy between labeled amounts and true content will introduce error into your analyses of nutrition and health outcomes. It's hard to get exact measures of intake, and so it's good practice to supplement your nutrition analyses with biomarkers of these nutrients whenever possible. And so in conclusion, assessing dietary supplements in pregnancy is key to fully understanding nutrient exposures during this very critical period of life for both mom and baby. Collecting critical details can help you construct a comprehensive record of supplement use in pregnancy that can be examined in relation to health outcomes. There are a variety of approaches to assess dietary supplements, and the best method for a given project will depend on the research question and the resources available. I will go ahead and end there. Thank you so much for your attention.
Okay, great. So good morning. Thank you so much for the invitation to be part of this webinar. I am looking forward to sharing how we're approaching dietary assessment in my ongoing pregnancy cohort study, the Mother-Infant Nutrition Study, or MINT. I'll discuss our initial plans, what we're actually doing now, and then also talk about what gaps remain. So MINT, the Mother-Infant Nutrition Study, is based here in Austin, Texas, and it was designed to nutritionally phenotype pregnant women. Our primary objectives are to examine the determinants of maternal weight and fat mass changes during pregnancy, including diet and physical activity assessment, and then examine how maternal fat mass changes are related to mom's weight trajectories, and then how both relate to neonatal adiposity. In addition, we're also interested in the role of diet in relation to pregnancy and birth outcomes. So MINT is a really intensive study with many measurements across pregnancy. And so as we designed our study, we had to consider participant burden when we were planning all of our measurements, as Anna Maria discussed. So this is just an overview of our pregnancy measures. Screening is aligned with prenatal care, and our first visit is at 14 weeks, so that our first primary exposure measurement, whole body MRI of body composition, would happen after the first trimester, and also ideally after nausea and vomiting from the first trimester has subsided for some of our participants. So our first visit is at 14 weeks, and at this visit we do body composition measurements, including MRI, anthropometry, etc. We give participants scales to take home. We do physical activity assessment with both the tigraphy and questionnaire. We do a whole bunch of biospecimen assessments and then also questionnaires. And then for dietary assessment, we do a diet history questionnaire 3, food frequency questionnaire, and then we also do an ASA 24-hour recall. So this visit is then repeated at 24 weeks and then 35 weeks gestation, so we can look at dietary changes over time. But because we were concerned about burden, we're only doing 24-hour recalls repeated throughout pregnancy. And I'll go into a little detail about that in a moment. So beyond our initial plans, which I just showed you, we also, as we were designing the study and getting ready to implement it, we decided to add a fruit and vegetable screener and then also a Vegimeter assessment as well, which I'll go into in a moment. So for our food frequency questionnaire, we were really interested in obtaining information about first trimester intakes. And we wanted something that was web-based and trimester specific. So what was available then was either a 1 month or 1 year questionnaire from the diet history questionnaire. So we ended up going with the past month, as we felt like the past year may not capture some of the changes that occurred in the first trimester in response to pregnancy, where there may have been more food aversions, nausea, or other changes that would not necessarily be reflected in the FFQ from a year. And we would have really actually liked to have a 3-month or even a trimester specific time period available in a web-based FFQ, but it wasn't available at the time. So when we were considering this, we wanted it to be web-based. We were considering costs. And so we have a very expensive MRI assessment, so we needed this assessment to be relatively low in cost, and it is. And then we also needed something that was in English and Spanish, and so that was why we selected this one. So right now, the diet history questionnaire in our currently enrolled participants has a completion rate of about 89%. And so now I'm just going to discuss our 24-hour recalls. So for 24-hour recalls, we use the ASA 24. This is an automated and self-administered 24-hour recall that we administer at 14, 24, and 35 weeks gestation. We do 1 recall at each visit. We would have really liked to do 2 recalls at each visit, but our participant burden is already quite high. So we ended up deciding to just do 1. And even with this just 1 recall, our completion rate is only 91%, which is pretty great, but it's not exactly where we want it to be. We wish it would be 100. Pre-COVID, we actually had our participants complete their recalls with us during the visit, at least their first one, just in case we needed to help them troubleshoot. And now, since post-COVID, we have to limit our in-person visit timing. So we actually just tell them what to expect, and we ask our participants to complete it on a normal day of eating, so no parties or anything weird or special. We would have really liked to do an interview administered 24-hour recall, but because of our MRI costs and participant burden, we chose to use the self-administered recall that was available in both English and Spanish. And so one of the other things I wanted to mention is that we see some lack of representation in some of the foods that our participants are choosing. And when we have to go in and match on the back end, we only really see Hispanic foods of both Mexican and Puerto Rican varieties, but we're missing some of the other foods that some of our participants are consuming. And then we also have some challenges with certain mixed foods as well. So we have a lot of challenges with mixed dishes, such as like Indian food dishes like dal or a chicken masala curry, for example. Okay, so moving on. So in addition to our routine assessments that we do, the 3 24-hour recalls, we also have a brief veggie screener that we're administering at 24 weeks gestation. And we're using the block fruit, vegetable, and fiber screener, which has a completion rate of 92%, so a little bit higher than the other ones. And it's very short, and it allows us to rank fruit and vegetable intake in our participants. In addition to that, we are using the Vegimeter, which is a non-invasive device that measures skin carotenoids using reflectance spectroscopy. And basically it shines light on one finger and measures the reflected light very quickly. One of my colleagues just had finished a school garden trial, and so we had the Vegimeter on hand, and so we added to our study as an exploratory measure. It's non-invasive, and it's a rapid way to assess the skin carotenoids, but we don't really know how well it performs during pregnancy, and we're not really aware right now of other studies actually using it in pregnant women to assess skin carotenoids. The best thing about this measure is that we have 100% completion when we actually have face-to-face visits with our participants, so we've even brought it to people's homes to do the assessment as well. So beyond these, some of the other things that Anna Maria mentioned are things that you may want to consider when you're thinking about dietary assessment during pregnancy. And so we're actually implementing several other measures in our study, including a mindful eating questionnaire and a food security survey. We're also assessing eating disorder the diagnostic scale. And then we're also asking if our participants are eating non-food items. And so we have just 2 very brief questions on pica. Beyond that, the study was implemented pre and then now post-COVID. And so we're actually, with our participants that were enrolled pre-COVID, we actually designed and implemented qualitative interviews to assess how the pandemic affected eating behaviors and diet, as well as our participant activity, mood, and health, in order to better contextualize our quantitative findings. Finally, we also needed to measure prenatal outcomes and other things that may be impacted by diet. And so we obtain really detailed information on pregnancy outcomes, medications, and then complications. And we do this through multiple methods. And so we have a separate medication and supplement questionnaire at each visit that's given on top of the supplement questions in the ASA 24. We also obtain prenatal care records to examine glucose tolerance and other complications, such as blood pressure. And then we also abstract delivery records as well. We assess nausea and vomiting in multiple ways. So we obviously ask participants to complete their recalls on a typical day. So if they're having a lot of nausea, we ask them to try and not complete it on that day, unless that day is typical for their entire pregnancy. And then we also ascertain if they're on medications that help control nausea, just to make sure that that we're really understanding what's actually going on with their appetite and eating behaviors. Beyond that, I want to just briefly mention our data cleaning and analysis considerations. So we're still actively collecting data, but we've come up with some initial guidelines. We haven't fully decided on this, but we may actually adapt our calorie cut points for low or high values based on trimester-specific needs. And we also are checking for both portion and nutrient outliers on 24-hour recalls, examining for large gaps in time on 24-hour recalls, and then adjusting for weekend status of the 24-hour recall, and then also considering season of intake and analyses. And as I mentioned, we're still actively collecting data, but we're eventually going to compare results from each of the dietary measures to see how concordant they are. So in summary, dietary assessment in our intensive study, our best options were actually web-based, and we really carefully considered participant burden. We really need rapid assessment tools in order to ensure that we actually get the data that we need. And then we also need updated food databases. And then it would be super to have integration of questions on nausea and vomiting into these web-based tools. And with that, I want to thank my lab and thank you all for your attention.
So hi everyone. I first want to thank the webinar organizers for inviting me to speak about diet assessment from a French-Canadian perspective. So I will do my best to switch to English, which doesn't happen often. Sorry for my French accent. The presentation will be divided into 4 short sections. I will first present the tools we use to assess dietary intakes. So we used a web-based 24-hour dietary recall that was developed by my colleagues from Université Laval. Benoît Lamarche, Simone Lemieux, and Julie Robitaille led that development. This tool was developed in French and then translated in English. It is inspired by the USDA automated multiple pass method, and it is designed as a meal-based approach. It includes a large list of food items and recipes representing what is eaten among Quebec consumers. Additional studies have demonstrated its validity among French Canadians. The tool is easily used by participants in various studies. Emails are automatically sent to the participants. The completion takes about 20 to 30 minutes, and to get better results and less error measures, participants should complete 3 recalls. If the participant does not complete the recall within 24 hours, a new date is automatically set by the system until all recalls are completed. So the recall contains questions about the meal context. Food and drinks are selected from a structured list. Portions are selected using food pictures, and the recall also contains questions on additions as well as on food and drinks that could have been forgotten. Once the recall is completed, the system automatically generates a complete report that allows us to obtain a list of several nutrients. Canada's food guide servings, and diet quality scores, namely a healthy eating index score. Just to make sure we are on the same page before presenting our supplement questionnaire, here are the Canadian recommendations for the dietary supplements during pregnancy. So women are told to take a multivitamin containing 0.4 milligram folic acid, as well as to 16 to 20 milligram of iron. So we use a web-based questionnaire in which the women have to answer 5 questions about supplement intake in the last month. There are questions on the name, the drug identification number, the unit of measure, the dose of the supplement, and the frequency. Women can enter up to 10 different dietary supplements. With the drug identification number given by the participant, we can have the specific micronutrient content, which can be found on Health Canada's health project database. I will now present the ANGE study that took place in my lab. So we conducted a study that aimed to validate the diet recall I just presented to you, but in pregnant women. And then if the tool proves is valid, we wanted to measure changes in dietary intakes throughout trimesters and to assess pregnant women's dietary intakes in comparison with the Canadian nutritional recommendations. So I present here the study protocol. Data was collected at each trimester. So women were first asked to complete online questionnaires. So we have 3 diet recalls and a food record at each trimester. Then we have the dietary supplement questionnaire. Other questionnaires were also completed on other factors influencing food intake. For example, a questionnaire on nausea and vomiting. And the women also had on-site visits during which blood samples and anthropometric measurements were taken. We also collected several data in hospital records. We recruited 86 women between April 2016 and May 2017. I will now present some results from that study. So for the validation objective, 60 women have to complete both the food records and 3 diet recalls within each trimester. 92% complete 9 diet recalls. The other 5 women complete 8 of the 9 required diet recalls. 97% completed all 3 food records. The other 2 women partially completed 1 of their 3 food records. Completion time is shown here. So it took around 20 minutes at each time point with a decrease over time. I will not describe all analysis we did, but overall, we found that the diet recall is a valid method to assess intakes of energy and most nutrients. So afterwards, we were interested to examine trimester-specific dietary intakes. So 79 women were included. 74 women filled all 9 dietary recalls, but the 5 other women completed 8 of the 9 required diet recall. Completion time was equivalent to what I presented you before. So as you can see, energy intake were stable throughout pregnancy, which translates into the fact that most women exceeded their energy needs in the first trimester, while the contrary was observed in the last trimester. Regarding protein, all women were within the acceptable range, distribution range, which means between 10 to 35%. A quarter of women were below the acceptable distribution range at each trimester. And for carbohydrates, the half of women were above, for fat, the half of women were above the recommendation for fat. Here I present you the results in grams and calories, which illustrates the stability we have observed both for energy and for macronutrients. Here are some of the results related to some micronutrients. So first, a large majority of women took at least one supplement. So prenatal multivitamins were used by 86, 85, and 79% of women in the first, second, and third trimester, respectively. And it decreased slightly, but non-significantly over time. For the next graph, intake from food is shown in black, and intake from supplement is shown in gray. So for folic acid, considering food only, around 60% of the women were below recommendation at each trimester. But when considering food and supplements, around 10% were below recommendations. For vitamin D, considering food only, around 85% of women were below recommendation. And considering food and supplement, there's still 20% that were below recommendations. Finally, for iron, considering food only, around 90% were below the recommendation at each trimester. And with supplements, 20% were below recommendation. So for those three nutrients, it shows the importance of taking supplement to reach recommendations. We also wanted to examine changes in diet quality throughout pregnancy and identify maternal characteristics associated with it. So we used the Canadian Healthy Eating Index, which measures adherence to the 2007 Canadian Food Guide. So we found a trend for a decrease in total HEY scores across trimesters. And we also found an overall significant decrease in the following subscores. So for adequacy, for total fruits and vegetables, for unsaturated fats, and for saturated fats. And we found that overall, younger women with no university degree and with poorer nutrition knowledge had a lower diet quality. So I'll finish by presenting you shortly some lessons learned, challenges, and perspectives. So first, the use of a web-based dietary recall was informative and appreciated by the participants. Second, we found important to have recruitment strategies to enroll women early. So we have worked closely with doctors who follow pregnant women, and we have proposed also a nuchal clarity ultrasound to all our participants. Third, even if the completion of the diet recall is online, it is important to maintain on-site visits when we can, because it creates a bond of trust with participants. We believe that longitudinal assessments of dietary intakes is still important, even if we observe no change for nutrients. We have to understand why there is a stability, and we did see a decrease in diet quality, which needs to be addressed. And finally, our relatively small sample did not allow us to observe association with pregnancy outcomes or gestational weight gains. So for all those reasons, I think that further studies are needed. Lastly, we have to remember that no diet assessment tool is perfect. So it is important to combine traditional tools with objective measurement method to get a better picture. So we did this in one study where we assessed vitamin D status during pregnancy, which provide us with interesting additional information. So I will end by thanking all the members of my team, collaborators, participants, and funding agency, and you for listening. Thank you.
Thank you, Kate, Beth, and Sophie. Those were excellent presentations. And now we want to open this up to questions from the workshop planning committee. And as soon as I see some hands up, I'll call on somebody, but I actually do have a question, and happy to have all three of you address it. So we know that dietary supplements is recommended to most pregnant women. And as each of you have shown, the fact is that a high percentage of women are reporting that they're taking these supplements. So given that high percentage, what happens when you actually go to assess total intake in pregnancy and you add the information from the dietary supplement? What happens to our wanting to look at either a group of nutrients or an individual nutrient then in an association between a total diet, a total nutrient effect, and a health outcome? Should you include it or should you not include it? And what's going to happen?
I think it depends on the outcome you want to study. I think that it is important to look at diet quality, even if we don't look at supplement intake, because it will give some information of some good association with some outcomes. However, if we want to see, for example, association with insulin resistance, for example, maybe we have to include supplement intake for vitamin D, for example. So I think it depends on the outcomes, but I feel that it's still important to look at diet quality and intake from food only to help women to get healthy eating habits that will last after pregnancy.
Thank you. Kate or Beth, do you want to contribute to that answer? Or do you agree?
Yeah, I'd love to jump in. Hopefully everyone can hear me now. I think assessing dietary supplements is really critical, especially when you're looking at the micronutrients. For example, folic acid. We saw from Aunt Sophia's data how high that folic acid intake is with the dietary supplements. And folic acid is a nice example because it's involved in 1-carbon metabolism. It's a methyl donor. And so if you're starting to look at associations between micronutrient intake and DNA methylation, if you're leaving out a high dose of one of those methyl donors, then you are missing out. You have an incomplete picture, and any assessments, conclusions that you draw from that will be incomplete. I agree, though, that diet quality is still a really important question. So it's good to get both pieces and to consider how perhaps bioavailability differs between supplement versus naturally occurring in foods. But there have been enough clinical trials demonstrating that, yes, taking dietary supplements in supplement form does benefit maternal-child outcomes. So including it is very important.
I third that, and I would probably agree with Kate, and I would show results with and then without in my analyses.
Great, thank you. Lisa Harnick has a question.
Wonderful presentations, everyone. I'm thinking with this, with pregnant women, social desirability bias in reporting is a real concern. I'm wondering if you could all share strategies you've tried using to minimize that issue.
So in our study, we use the web-based dietary recall. So we are not with the participants to judge any answer. This is the same for all the questionnaire we use. Still, there may be a risk for that, even if we are not there. But we have to work with that, I assume. So if we see, like I shown in my results, we see that the score of diet quality, I did not elaborate on that, but they're still low. So even if they report to better eat that they did, I think there's still some verity in that. I'm not sure it's clear what I said. Sorry for my English again, but I hope this answer is great.
Sophie, I agree. Go ahead, Beth, jump in.
So I just wanted to say that when we talk about all of our questionnaires with our participants, we really emphasize that we just want them to be true to what they're actually doing. We say we're not going to judge them for what they're eating or doing. And we try to really emphasize that. And I think also building our rapport with our participants and just making them feel really comfortable. I mean, our study takes we have 2-hour intensive visits during that session where we really try to build rapport and make sure everyone's comfortable and clear, and we try to be non-judgmental with everything, and we hope that helps as well. Kate, do you want to say something?
I agree with the non-judgmental. When you're doing it in person, building that rapport and showing your participants that you respect them, that you're not judging them, based on answers. If they report something like, I had 5 tacos from Taco Bell for lunch, there's no laughter, there's no, oh, wow, that's a lot. It's just, okay, did you add anything on top of that? Did you have any beverages? And you just move along and make them feel comfortable. And that's how we end up retaining our participants in these research studies anyway. We build good relationships with them.
It's particularly essential now that we're doing our study during the pandemic. Having the rapport really, I think, has enabled us to actually retain our participants despite all the challenges that they're facing right now.
Thank you. Donna DeBella?
Yes, thank you, Anna Maria. A question for any or all of you is how good are our references or guidelines at this point in time? And this pertains both to dietary supplements as well as for energy intake, macronutrient intake, micronutrient intake. We're still comparing with what we observe in our studies with recommended daily intakes or what we think the percentages should be. And then we conclude, oh, and these don't change a lot during pregnancy, but should they change? What kinds of studies do we need to conduct to determine in contemporary populations, pregnant women today, what they actually need to eat and what supplements they need to take? I think it's a broad question, so short answers are fine.
May start. In our study, we were surprised when we see that energy intakes were stable throughout pregnancy, since the recommendations is to increase energy intakes. So we are currently doing 2 different studies. The first is to study the appetite regulators that influence food intake during pregnancy. So I do not have results to share today because we don't have yet. But we also have another study that want to measure basal metabolic rate in a woman to see if there's still an increase that is supposed to fit with the 400 calories that is recommended. So maybe it's a little bit less. We did a literature review that look at that, and maybe it's a little bit too elevated for women to increase their energy intakes, and maybe it does not fit with appetite. Maybe their hunger starts in the first trimester, and maybe it's okay that energy intakes is stable. So that's a good question, and there are studies that are currently done for that. So this is what I can say for energy intakes.
I just want to add, maybe we might also need to consider energy intakes variability and where people start when they become pregnant. So women with severe obesity may have many different needs than women who begin pregnancy at a normal weight, even just considering the equation for calculating it.
Sure.
Maybe they need much less. So thank you.
Donna, in terms of how good are the recommendations, I want to point out that for the Institute of Medicine dietary reference intakes, there's about 20 micronutrients for which there's specific recommendations in pregnancy, but about half of them are based on needs in non-pregnant women, sometimes adjusted for what they expect that the fetus needs, but only about half of them come from actual studies in pregnant populations. So I agree that very well characterized, rigorously designed studies that assess well diet and supplement intake from preconception to delivery, supplemented with biomarkers so that we can look at a wide range of outcomes is really what we need to get better information about what should women be taking, not just what are they taking.
Thank you, speakers. Erica Gunderson.
Hi, very nice presentations. Thanks so much for those details and quite rigorous studies that you're doing. I want to shift back to your diet quality assessment, I think, and take a little bit of a deeper dive into some details, because I know the components are, contributing all facets of the diet, but I wanted you to comment on sugar sweetened beverages and fruit juice and sources of simple sugars. And somehow in infants, there has been some very nice, and young children, some very nice data showing these sort of simple measures Each of them are independently associated with child obesity. And as you all know, pregnancy metabolism shifts dramatically. So there are higher peaks in glucose and deeper valleys in glucose, even among women who don't develop gestational diabetes. So how is appetite stimulated? Are you thinking or planning of looking at sort of some of these specific dietary components that in a practical way, clinicians might be able to screen their patients for potential problems or risks? And I'll let any of you answer this, of course.
Well, Erica, I can just say that one of the eye-opening experiences I've had recently in conducting a pilot intervention study on mindfulness eating was the fact that we were meeting over the course of 8 weeks of delivering this intervention. And one individual who we developed a really wonderful relationship with, it wasn't until the third visit, after trying to figure out, why she wasn't feeling well and why she was gaining so much weight, was the fact that she was actually consuming 2 64 ounces of Minute Maid lemonade.
Yeah.
And she didn't consider that food. It was a
Yeah.
beverage.
Yeah.
And so it sort of speaks to this building of a rapport. It speaks to the assessment of food and beverages and stressing the importance of asking those questions about what women are drinking. Because if not, you miss like this really easy thing that you can help them to change. So I'll just contribute that.
Yeah, empty calories. But I'd love to hear the speakers and what your comments are and how your studies are addressing this issue, or future studies. You might give us techniques to focus on this. Or are there studies in pregnancy of focusing on these sorts of high sugar intakes?
Our diet quality scores did not look at those items specifically. We did not look at the sugars or only juice for the moment, which we can do. But we see in the other foods component of the diet quality that it did not change. So it's a good question. We definitely look at all those aspects in further study, and we can look back to see how it is in our data.
Great. Thank you.
So I'd like to call on our colleague Essa Davis to ask her questions.
Oh, sorry. Hi, this is Issa Davis. So I just was wondering if you all would be able to speak about the how good the assessment tools are in assessing the diversity in ethnic foods. And I know that they probably have gotten better over the years, but can you talk about kind of where we are now and, how we should think about those assessment tools being modified to be able to have a better representation of the different ethnic and cultural foods that are out there?
I can speak to that. So right now when we have participants that are eating certain ethnic foods, for example, so I mentioned the curry with chicken, for example, we have to go in and make it on our own on the backside. And it's really quite challenging, and it requires a lot of guesstimating. Even if someone's eating something that's a very commonly consumed food. So I think that there's a lot of room for improvement there.
So I think my situation is a little bit different because we were in Quebec City and we the recall was conceived to reflect Quebec consumers' intake, but there are a lot of food of different diversity, and this is adjust when as it advances in time. So we think that we have taken care of this, but it could be improved with time.
One tip that I would offer is that if you're entering a food that's not showing up in your database with a NDSR or something, store it in another place, because the ASA 24 and DSR, they are continually coming out with updates. And so it may not be available now, but in a year when your study is still ongoing, it may be in the system, and then you can add it at that point. So get as much detail as you can on the front end.
Good points. Call on my colleague, Stephen Daniels, to ask a question.
Hi, thanks. Those are great presentations. Beth, I appreciate your comments about the impact of morning sickness and nausea and vomiting on diet. I'm wondering if there are specific approaches to address issues of changes in taste preference during pregnancy, and how that might ultimately affect the overall diet.
I don't know of a questionnaire or something that really addresses that, but I mean, I think that we might be able to suss that out in like qualitative interviews, but obviously that won't really be available, like easy to use for researchers with larger populations. So I think that there's definitely a space for that.
Yes, we used a web-based questionnaire that look at the, what's the term in English? At cravings and aversions. So at each trimester, we ask the woman if there are some food that they really like to eat, or the inverse. So we look at the changes, and we see that cravings tend to decrease during time, and aversions also. The most thing that were disliked by participants what touch proteins. But we didn't see any associations with our results regarding diet quality or regarding total intakes. So maybe it's not a big part of the big picture, but I think it's important to look at that.
Yeah, I agree. We have assessed on cravings and aversions in our local cohorts, and here what's missing is a preconception baseline. So understanding what women were eating before, and then they may tell you, I'm craving chips, or I'm craving salty stuff or sweet stuff. But without having that preconception baseline, you can't tell if what they're craving, are they just thinking about it more, or does it actually translate into shifts in dietary intake?
Good points. Do any of my other colleagues have a question they want to ask? We have 1 minute. Cheryl, yes.
Yes, thank you so much, everyone, for that wonderful set of presentations. I just wanted to ask for a little bit of additional contextual information around the notion that there are some social and potentially some social factors that might be important in how you go about using these assessment tools. Some of you commented on level of education, socioeconomic status, et cetera. What's the state of affairs with regards to the tools that allow us to get those types of information well?
So if we have a participant that is of lower socioeconomic status or has less education, like we really hold their hands through the assessment process. And so even though we have the self-administered recalls, like we may end up doing it with them, where we actually fill out the questionnaires for them. But I feel like that doesn't really, it's not really accessible for everyone, because you have to have a lot of staff to actually be able to do that. So I guess the state of affairs is, again, there's more room for improvement there.
With dietary supplements, it's a bit easier if you can get women of all backgrounds, all situations, to bring in the items, the products that they're taking, and then you're not relying on their knowledge, their memory of it. But there still needs to be some education about what constitutes a dietary supplement versus nutritional supplements or protein drink supplements, those kind of things. So it's just a matter of talking it through with those women. But I don't think we have a good sense of how well their own background, their own education and training is influencing in the moment what they're telling us about their dietary intake.
Well, thank you, everybody. I'm going to have to end our question and answer period here to stay on time. We will now be taking a 5-minute break and come back at 11:15. And I want to thank everyone for a wonderful presentation and a good Q&A session. So thank you. I want to welcome everybody back and introduce our next speaker, who's Daniela Sotores Alvarez from the University of North Carolina, Chapel Hill. And Daniela will be talking about analytical methods to estimate dietary intake during pregnancy. Take it from here, Daniela.
Can you hear me and see the slide?
Yes.
Okay, great. Thank you. Hi, everyone. Thank you very much for the organizers for the invitation. So I'm going to be talking about analytical methods to estimate diet intake in the context of pregnancy, but these methods are applicable to any population. Okay. So I'll start with a measurement error on self-reported diet intake. I'll move to estimate the usual intake from foods and beverages and how we can include the supplement use. I'll touch very briefly on when we are interested in looking at diet and health outcomes associations, how can we use a regression calibration if we're lucky and fortunate to have biomarkers. I'll end with some of the best practices and future directions and some of the resources so that you can learn more about these topics. So some of the types of measurement error include having random error, which would be variability from day to day. There's also systematic error that can be general, so there will be no differences between people. But most of the time, we have person-specific bias, for example, for age or by BMI or social desirability, such like we were discussing before. There's also intake-related bias, which can be seen for people that have low intake are some of the times over-reporting, and vice versa. People with high intake tend to under-report. So depending on the type of error, its impact will be different, depending whether we're interested in the distribution or whether we're interested in an association between diet and a health outcome. So it depends on the type of error, and most of the time it's the random error and the person-specific bias that have a largest impact. So what can we do? So we definitely need additional information, and as we saw from previous presentations, we can have several dietary instruments. Each one has their strengths, so they can complement. If we're having 24-hour recalls or food records, it's important to have repeated measures because of these high variability within a person. We can also have covariates that can explain or help us explain some of the specific bias from the person. And as we'll see later on, we can also include or combine instruments. So we can include the food propensity questionnaire as a covariate, or also whether the person is consuming supplements or not. And then for a very few nutrients, there are some biomarkers, recovery or concentration biomarkers, so we can have a validation study for our self-reported instruments. But these are usually on a small sample because some of them are expensive, like double level water, and some are a high burden on the participant, like collecting 24-hour urine for urinary nitrogen for protein, or for estimating sodium intake. So I'm gonna spend some time on showing on a figure what's the impact of random error in estimating a usual intake. So on this figure, let's first focus on the green distribution. So that would be the usual intake distribution without random error. So for example, the true intake that of course we don't observe. Now let's say that we have two 24-hour recalls and that we average them. So the orange distribution is showing how the distribution that we would observe from the 2-day mean when we have only random error. And as you can see, it's much wide than the true intake, the green, but the means are equal. So if we're only interested in the means, then having the average of 2 recalls, if we are sure that we only have random error, that's probably a good idea. But if we're interested in the tails, which is many times the case, then we have a problem. So let's now think that we have several 24-hour recalls or several food records, and that we're going to be using a statistical model. So let's say we have the blue distribution. So now the tails are less wide than only doing the 2-day mean, but we have systematic underreporting. So now the tails are less wide, but estimates are still biased. And as you can see from the tails of these different distributions, which is just hypothetical, it really makes a difference whether the tails are longer or not when we're interested in estimating, say, the percentage of people meeting the requirements or looking at tolerable upper intake level. So it's very important that we account for measurement error. I'm going to spend a little bit of time on how we can estimate usual intake from foods and beverages when we have multiple 24-hour recalls or multiple food records. So there are different methods to estimate usual intake. Here are the most well-known, and I'm providing some references on how we can compare these methods. And I'll focus on the NCI method, which is the one that is more widely used in the US. So the NCI method has SAS macros available, so people can use them. It allows estimating a nutrient or food usual intake for those foods that are consumed every day. It will model the amount. And for those that are episodically consumed, it's a two-part model where we model jointly the amount and also the probability of consuming that specific food on any given day. It accounts for the day-to-day variability that we saw before. It will make a difference if we don't account for it. It accommodates highly skewed variables seen in dietary intake. It allows relating covariates to usual intake, which helps improve the estimates by explaining some of the variability. It also allows estimating the distribution for the population or for specific subpopulations. And it corrects, at least partially, the bias caused by measurement error in estimated associations between usual dietary intakes and health outcomes. But it's important to note that it assumes that the reference instrument, say 24-hour recalls, are unbiased of the true usual intake, which is not always the case. The NCI method has different macros available if we're interested only in a single dietary component, say sodium intake, or a macro when we're interested in 2 dietary components. You want to model or estimate the distribution of sodium intake per 1,000 calories. It also has macros when we're interested in multiple dietary components, say the diet quality indices, healthy eating index. Now, as we saw from previous presentations, during pregnancy, many women take supplements that obviously will vary from populations, but we want to make sure that we can incorporate the dietary supplements when we're trying to estimate the distribution of intake coming from both sources, the foods and beverages, as well as diet supplements. And this usual intake distribution, we need multiple 24-hour recalls or multiple food records. So some of the challenges specific when we're trying to incorporate supplements is that now we have measurement error from both sources. So it's the one that comes from the foods, the one that comes from supplements, which has been less studied, and the structure is less known on even just the supplements or how it's combined with foods. Now, by adding the supplements, it also makes the distributions more skewed. And it also has spikes because there are common dosages of the supplements, and it can be multimodal or bimodal if the consumers are having a higher intake, as it has been shown, and also in addition taking the supplement. We also know that there's correlation between the supplement use and the diet intake. It has been shown that those that are taking supplements in general have a higher intake, and also there can be some healthy user effects. So those that take supplements have greater access to healthcare, may have a higher education, and these can lead to some differential measurement error between those that take supplements and those that don't. So now we have these two subpopulations, those that consume a supplement and those that don't. And we want to estimate the total usual intake. So this paper by Dr. Regan Bailey, which I know is here as a participant, has described very nicely the different methods that have been used. And there's really no right method to model the total usual intake at the group level. The method, it will really depend on the research question, on the sample or the population characteristics, what's the sample size, and the percentage of consuming dietary supplements. But these are three general categories of methods. So one would be the combined method, where we are going to estimate the usual intake, combining users and non-users. And the preferred method is having what is called shrink then add. So by what we mean with shrink is that we'll first estimate the usual intake coming from food sources and account for the within person variability. And then we'll add the supplements for those that consume the supplements, and that combination, which is modeled simultaneously, will be the distribution. And from the previous discussion about the NCI method, here it's an example where we would include as a covariate whether the women takes supplements or not. Then we can also study, if we're interested, on stratify analysis, where we estimate the distribution separately among dietary supplement users and among non-users. Or there's a hybrid model where it's a three-part model where we'll model in two parts. We'll model each the intake or the amount from foods, depending on whether it's a user or non-user, and a three part of the model is estimating what is the probability or the percentage of consuming supplements on any given day. So again, these are three general methods, and it depends on different characteristics which method might work better. This is an example of a manuscript also on the estimation of total usual diet intake in pregnant women in the US. And specifically, this figure shows the percentage of women or pregnant women below the estimated average requirement for folate and iron. The blue bars show the nutrients from food sources, and the white bar is the total, so combining foods and supplements among those that consume it. So for folate, we see that coming from food sources, about 38% are below the requirement, both for users and non-users. And then when we focus on those that consume supplements and we consider both sources, it decreases and it's only about 5%. For iron, we can see here that iron coming from food sources, it varies depending whether the women consume it or not, supplements. And then once we incorporate the supplements to the food sources, the percentage of women not meeting the requirements, it's much lower. So now let's just shift a little bit gears. If we're interested in looking at the association between diet and a health outcome, and if we have a recovery biomarker, then we can use a technique which is the regression calibration. And this is just a very simplistic figure showing what can be the impact of measurement error. So on the blue dots and the blue line, it's what it's unobserved is the usual intake. And here we are showing with red what is that we observe and how these association would be attenuated if we don't account for measurement error. So on the regression calibration, we first would fit a model where we would regress the recovery biomarker on the diet instrument measured with error. And usually, as I mentioned, there's only available the biomarker in a subsample. And then we can use these predicted value of the biomarker in the full population to assess the association of interest. And then these association would be unbiased or at least less biased than it would be if we just use instrument with measurement error and we don't account for it.
So Daniela, that I think you're on your last slide. We need to move to the questions session very soon. We're on a tight time schedule, so perhaps we can follow up with some questions about your presentation.
Absolutely fine. I'll just end with some great resources, the webinar series on measurement error and the National Cancer Institute Dietary Assessment Primer. So thank you very much, and we can move on to the Q&A.
Great, thanks so much, very much. We're going to start, I'm Erica Gunderson, I'm the moderator, so we're going to start with some questions from the scientists and the participants with raising your hand. So are there any of the panel that would like to ask? Nancy, I see your hand, go right ahead and ask a question.
Hi, Daniela. I really appreciated your review of a topic that I'm fairly familiar with. I was interested in your comment about concentration biomarkers. You didn't present on that, but given the huge difference in plasma volume expansion across women, it seems like it would be very hard to use concentration biomarkers for validation of dietary intake. Do you have any comment on that?
Yes, I agree. It would be desirable to have. Unfortunately, we still have very few recovery biomarkers or concentration markers, but it would be the ideal to have these and being able to measure across the pregnancy.
Great. So are there any other questions from our committee members on the analysis? I think that your analysis, Daniela, really focused on some of the major problems with the assessment and repeated measurements. Maybe you could talk more about, you have the biomarker calibration equations as trying to really get it true intake, but are there any other ways that you can, other than the validation, you mentioned validation studies, are there any ways that we can correct the data or do more analysis in terms of diet quality to assess errors?
Yeah, Absolutely. It's, as I mentioned, it's very few nutrients that we have recovery biomarkers. So there's definitely more research is needed in order to identify new biomarkers. So for the vast majority of the nutrients, pretty much all of them, we don't have biomarkers. And when we're also interested in specific foods or food groups, we really still don't have those predictive biomarkers that would be good to estimate, I don't know, consumption of vegetables or different food groups. So what we can do there is what I was describing with the NCI method, but it's really critical that we have repeated measures so that we can account for the within person variability. And it doesn't need to be on all our sample. At least we have in a subsample some of the repeated. This method allows incorporating all of the measures that are available for each participant. And in combination, it can reduce the self-reported or the within person variability. And we can include the food propensity questionnaire, for example, as a covariate or an indicator whether the woman is taking dietary supplements or not. So we reduce very significantly the within person variability, which is where there's more impact if we're interested in the distribution, and also if we're interested in the associations, which many times is attenuated. So yes, we definitely can combine the different instruments in order to best address or mitigate the effect of random error.
Great. Donna, go ahead. I see your hand raised.
Thank you. Thank you, Daniela. I'm Donna DeBailey. I'm one of the members of the planning committee. I just realized that we never introduced the members of the planning committee. My question is about the portion of your talk when you talked about combining estimates of micronutrients coming from food and coming from supplements. And I know you talked about different methods that might be more or less appropriate depending on your research question or population characteristics. My question is, what do we do when we have, a large, very large study where data were collected with various instruments, both for a dietary recall and for nutrient intake, and we still want to combine because our research question is about a combined effect? How do we even approach that difficult
Yes. So, I was talking about having multiple records, 24-hour recalls or food records. Ideally, we would also want to have the supplement asked on that specific day. But most of the time it's asked with questionnaires. But if we have them both, that's even better. So the more information we have, the more confident we can be that we're getting a less biased estimate. So we can still have the both the foods and the supplements measured with 24-hour recalls, and also incorporate what we would learn from a questionnaire, which they can ask from the last 30 days. And so someone that didn't take the supplement for whatever reason, and those 2 days that we happen to ask them, we would still capture that if we either collected with a recall from the last 30 days or from a questionnaire. The problem with a questionnaire is we'll miss frequency, and sometimes, as we heard before, even if we get to know the brand, there may be differences. So again, the more we can, the more instruments we can have, the better we can estimate. And these methods allow combining instruments that they can complement and help us better estimate the total intake from foods and beverages and also from supplements.
Great.
Follow-up question. Are they then comparable if they were assessed with different instruments?
They are complementing each other. So if they're different instruments, we are thinking that the instruments were chosen because we thought they could complement each other. So I'm here thinking just on having the repeated from the 24-hour recalls, on not only foods, but also supplements, and combining it with an instrument that can measure for a more long-term use of the supplements. So am I understanding your question?
Yeah, thank you.
Great. Well, thank you very much for participating in this portion with the Q&A. Now we're going to open up the panel discussion to the entire group of speakers and the committee members and scientists. So please, unmute and be on video, and we'll take questions from the attendees. That I know that if you would like to ask a question, please submit it through the Q&A box, and we'll read your questions and indicate which speaker you'd like to direct your question to as well. I have, and anyone is able to ask a question at this point. So I do have some questions that were basically asking about assessments of dietary supplements. It was mentioned that the actual content of the supplement may differ from what is in the supplement label, and therefore biomarkers of intake may help. However, biomarkers of dietary intake of micronutrients, food and supplements, if available, do not necessarily differentiate what comes from food from those provided by supplements. So that question has to do with the use of the biomarkers as I interpret it. So are there any comments about how, if you have these two different sources of intake, supplements and food, how do you interpret biomarkers based on that sort of distribution? Anyone would like to address that, the speakers?
Sure, I can jump in.
Great.
I think that the key here is we're interested in the total exposure that this woman and her this pregnant woman and her fetus are getting. So it's not so much that we want to separate within the biomarker what comes from food versus what comes from supplement. It's more about looking at what bioavailable amounts are in the body and how is that total amount, no matter how you get it, impacting the mother's nutrient stores and crossing or not crossing the placenta and affecting the fetus nutrient stores. So I don't think it's so important to be able to separate between food versus dietary supplement source, but we want to know what actually gets into the body, what is absorbed through the digestive system, and how does that become available?
Yeah, and there was a corollary question to this issue as well, which you're starting to address, which has to do with the bioavailability. And that's the follow-up piece of this is, I had this thought as well. You have these supplements under different labels with different chemical compositions, and they certainly have different bioavailabilities. But if your instrument of assessment of the supplement is just saying there's X amount of folate, there's X amount of iron, but there's variation in the chemical composition, hence variation in bioavailability of the nutrients from different supplements. That would be, the biomarkers would certainly be able to measure that. But what about, most studies don't have biomarkers. So are there methods that sort of take into account the bioavailability of the chemical composition, or even the combination of micronutrients like zinc and copper that the absorption can be interfered on by large amounts of iron in supplements? So maybe you could comment on that, because that's the gist of the corollary question from the same person.
Sure, I think this is a difficult topic. We are talking right here about micronutrients, but the same thing happens with macronutrients. If you're eating a fully carbohydrate-rich meal versus carbs being consumed with fat or proteins with fat, there's going to be differences across women and differences across amounts of how that is processed in the body. So this, unfortunately, is a really difficult area to get a very clear sense of what's going on in the woman's body without doing more mechanistic studies and studies where you have very measured amounts that are being fed to the women, and you can do continuous blood draws to see what's showing up in the body. So I actually don't think we have a lot of good evidence from studies in pregnancy, and it's something that needs to be kept in mind as you're looking at the total amounts that are being consumed, even what's showing up in the blood, and trying to relate it to any health outcomes. It's definitely a challenging spot.
It sounds like biomarkers are of high importance for certain questions that about requirements and supplements and diet. Great. Okay, let's see. I have another question. Do we really know on everyday usage of dietary supplements? This person says their recent experience with clients is they are not taking them because the iron is constipating.
So I can address that question. One of the first studies I did as a researcher was to actually assess dietary supplement intake during pregnancy. And we used one of those little MIMS caps on the supplement bottle to see how often women actually took their supplements and compared it to their self-report. Guess what? It was a very poor correlation between the actual intake of those supplements and how people self-report. So this is where I do think you actually get that social desirability bias in those reports. Yeah, so I think you need to be careful with that. And it's not only due to women's perceptions, and we can do something with counseling on women's perception about the iron there, making sure that they get enough fiber and drink enough water. But I just think it's the reality of it is that people do their best at the beginning of pregnancy, and then as pregnancy takes its course, they tend to forget. It's kind of human behavior.
Do you think, so Anna Maria, just as a follow-up, do you think studies should issue these some sort of digital mechanism to count supplements? Should studies that really want to look at nutrient intake and its adequacy and pregnancy outcomes be issuing those sorts of methods where you don't do a verbal report, self-report, but you actually give objective methodologies to try to see what their actual intake is?
So I think this goes back to, those things are expensive, number one. So I'm not sure that every study can actually afford to use that. I think it goes back to the research question. What exactly is it that you're focusing on? And if you're focusing on a particular nutrient, it might be better off using an assay, so a biomarker, to be able to assess what is the body actually sort of being seen. So, what is that sort of physiological marker that we're interested in? And that's going to assess whether it comes from diet or the supplement. And you should be able to, if you have that on your full population, you should be able to pretty quickly distinguish who's taking a supplement and who's only on diet, because you'll actually see that separation in those bioassay marker results.
Okay, great. Yes, hopefully, and biomarkers are tough sometimes as well, but for certain nutrients, but there are some where they're very, very good representation. So there are a couple I'm just going to focus on the dietary supplements and then move to some other questions, but here's another dietary supplement question. There is evidence that some micronutrients available in supplements, folic acid, calcium, have a biological effect have the same, I guess they mean the same biological effect as naturally occurring in foods. Is it known whether all the many micronutrients in supplements have the same effect as the same micronutrients in naturally occurring foods?
I don't think it's known exclusively across all micronutrients that they're all exactly the same, but the evidence we do have is that most of them, it is pretty similar, whether it's naturally occurring versus synthetic. And this also goes back to the previous question about interactions between medication, between supplements and foods that are being eaten together, and whether you hit these points of max absorption. So if you take a bolus amount of certain supplements, they will be able to be absorbed into the fat stores and they can stay in your body, and others will just be excreted. So it's not just about the type, but it's also the amount that's coming in and whether it's going to have the same effect if your body can absorb it well.
So here's a question about food frequency methodology. So first, thank you for the good presentations. First question is that some of us worry about exactly what FFQ measure, the psychology of memory that is involved. Beth Loftus at UCSF has done some interesting work on memory and false memory, now extended to foods that also may extend to diet as well. What do participants think is being measured? Second, how about a common prenatal supplement list to add to FFQ to remedy lack of uniformity and what is queried on them? So two-part question. The first one has to do with, I think it's really relevant to pregnancy, particularly across time, and this whole issue of memory, and because of the short time interval that people are being asked to do these FFQs, which can be quite long and tedious. So any of you that are using these methods or trying to interpret them, can you answer the, comment on this issue or whether you think it's relevant?
I think most of us here actually use 24-hour recalls or food records because we do see challenges with the food frequency questionnaire. A lot of groups can try to change the FFQ recall period during pregnancy to not look at the past year. Obviously, they weren't pregnant during that time, but to do a shorter window, and some FFQs are validated to that. But it is certainly challenging to get an accurate assessment of what women are consuming and how they're reporting it, especially when you bring in seasonality, and it can be very difficult.
It's more of a population level measure specifically, and not so much individual level, but it has its appropriate uses. Anything about the prenatal supplement part to the FFQ is
that might be beneficial, but adding the prenatal supplement list might be beneficial, but I think that the supplements are really changing quite rapidly, so it just might not necessarily be able to keep up with what's actually happening in the market.
Right, like the food issues, some of the food composition issues. It's a moving target, all of these sorts of different items. So then this is an interesting question about, is there, so examining developmental outcomes for offspring and 24-hour recalls. Do you recommend that each trimester for the 24-hour recalls? And then this hypothesis about epigenetic phenomenon and surveillance studies that look at these developmental outcomes. Would you suggest these multiple 24-hour recalls, or what essential nutrients, these micronutrients like copper and zinc or iron? That's a global question about studies and appropriateness. I think we have about one more minute. So we've had some really very interesting questions come up, and I wish we could address more of them. But I think—
Erica, can I just respond to that? Because I think that's a theme that sort of has come out with all of the presenters. So most of our presenters used not only 24-hour recalls, but they used 24-hour recalls. They use food records as well. And some of them also use food frequency questionnaire. And I think, Anne-Sophie, you presented some very interesting data. And I know that Kate and Donna had data on this as well, because they followed my guidance and telling them to collect as many 24-hour recalls as they could. If in fact we really see sort of a stabilization of diet over the course and we're not seeing differences, if we wanted to plan a new study, and given the respondent burden that you're placing on your pregnant population, how many recalls or assessments should we really be doing?
Yeah, that's the question, I think. We all want to know the answer, especially with the stability that we saw. What are we gaining with multiple 24-hour recalls? 3 days, multiple times.
I think this goes back to Daniela, the fact of, it really depends, right? Daniela, if you can have it on a subgroup and be able to look at that intra-individual variation and account for it, the question is, what do we need?
Yeah.
Yes, absolutely. No, it will also vary by nutrient, right? And so you still may want to be interested on each trimester, but yes, for large studies, these may not be feasible. So maybe it's 2 recalls or 3 recalls across pregnancy.
I think it also depends on if there's a specific nutrient that may have an impact at a specific time that you're really interested in. Maybe focus on that particular nutrient with like a focus screener or something like that, where you have really dedicated questions getting after that particular nutrient. That might be a way to tease it apart rather than doing multiple 24-hour recalls.
I think a good example is neural tube defects in the periconceptual period. You've got to get sufficiency of folate during that early window of gestation and preconception to avoid, to target the neural tube sort of window of development. So if you're interested in that, and there's a lot of studies that have already looked at that, but any nuance in that has to do with more mild things, you may want to focus on that period, and then another period later on maybe is not as crucial for that sort of a study.
I wanted to say, as somebody who has collected a ton of dietary data during pregnancy and by multiple methods, I, for one, to respond to Anna Maria's question, I would like to first validate this finding from a small longitudinal study in Canada in a larger population to see indeed if these intakes are stable during pregnancy. And if they are, I probably would not collect multiple longitudinal methods, but I would collect a diet in multiple ways. In the period that is more interesting or of more interest given my research question, whether that's the first trimester, the last trimester, the middle pregnancy, but I would collect multiple ways in 24-hour recalls, food frequency, maybe biomarkers, supplements. I think that the key is having multiple ways of assessing nutrient intakes rather than necessarily longitudinal methods, although we need to validate that observation.
Comprehensiveness, definitely comprehensive, and multiple new methods that we're going to hear in some of the other webinars coming up. I think this is a good segue to our subsequent webinar 2 and 3. And I'm going to thank everybody for their questions. We didn't get to all of them. I wish we could have, but certainly continue to participate and ask questions. And I'm going to hand off to Cheryl Anderson to wrap up our webinar. Thank you to all the committee members, scientists, the attendees for questions, and the speakers. Great job.
Yeah, thank you so much, Erica, for that. I'll just share my screen quickly with you for a few last minute thoughts. So thank you so much to our presenters. You've done a fantastic job with us today. We heard a few take-home points, right? Pregnancy is a vulnerable time period, and women report making changes. A high percentage are using supplements. I loved hearing that our ultimate goal is really, we want to understand the bioavailability of nutrients for women who are pregnant. And, we want to have good methods, our good survey methods are good biomarkers to help us do that. Validation is incredibly important in this work. Currently, biomarkers are quite limited. And while no tool is perfect, we do have the opportunity to combine them, multimodal complementary tools. However, keeping some analytic considerations for how we compare findings once we've done that. And then lastly, as we wrap up, I just want to remind you of our upcoming webinar on Monday, May 17th. It will focus on dietary assessment in children ages 2 to 5, and I hope that you will join us for that session. So thank you everyone for your time and attention this morning. Thank you to our planning committee and to those of you who took time out of your busy days to be with us.